Hello, and thank you for inviting me to Brisbane. I wish I could have been there in person. I'm Jim Rudolph. I'm a geriatrician and palliative care physician based in the United States, and my work focuses on improving the quality of care we deliver in U.S. nursing homes. You call them aged care homes. We agree that they're places where people go when they can't take care of themselves. Um, I'm yet to meet the person who says, gosh, I want to go to a nursing home. It just doesn't happen. The people who are admitted to these facilities have lots of medical problems. They have reduced functional abilities, meaning that we need to complete those functional abilities so that they can survive and live. Often the supports they need to manage those functional abilities and the medical conditions are beyond what's capable in their social support network. And so the network collapses and they end up in the aged care homes. There are also a number of unsafe behaviors which have a predisposition towards ending up in a aged care home. Care homes meet the needs of the people who live there, right? There's shelter, there's food, there's heat, air conditioning. If you're in the north of Australia or the central of Australia, there's also the daily care needs: cleaning, grooming, bathing, toileting. All of those necessary components just to get by are delivered by the care homes. Care homes also will deliver advanced therapies, and we don't think of medication administration necessarily as an advanced therapy, but the reality is it's a very complex cognitive process, and aged care homes manage that process for the people who live there. In the U.S., there's been a large focus on meeting the social needs of people by living in that community of other older people. And so there's a focus on engagement and recreational activities, at least prior to COVID. Care home employees work really hard, all right? It's work that you have to have a passion for doing. If it's just a job, at least in the U.S., there's way better places to earn that amount of money than through there. Remember that the people who are admitted to aged care homes often have cognitive and functional deficits, and so the care home workers have to do the most intimate daily activities with these people, and it's really, really hard. Cleaning diapers and feeding people. You're in their space. It's really a challenging job. It's important. As in the U.S., Australia, aged care homes are a business, right? You have to, the money coming in has to at least equal the money going out. Otherwise, it's not a viable business. In my research for this talk, there are about 875 care homes in Australia. Like the U.S., a large percentage are for-profit. There's a number of nonprofits and a number of government-run facilities as well. The industry generates $18 billion in revenue, but only pulls in about $0.4 billion in profit. And you go, geez, that's $400 million. That's a lot of money. You're right, it's a lot of money, but at a 2% profit margin, you can bet that about half of those homes just aren't pulling in the necessary money to meet their own needs as a care home. And if there's no margin, there's no mission. That makes it a really tough business. When you're looking at a low margin business, cutting corners will happen more frequently, and it's the data out of Australia look as though this is actuality. 10 to 16% of homes are not viable. Depends on which model you run, but they are losing more money than they're bringing in, and it looks like it's a sustained loss. And then roughly 50% are right on that bubble. And with a 2% profit margin, that's consistent with what you'd expect. In case you're not aware, there's an increased spotlight on care homes. first there was the Royal Commission, and it was a pretty scathing response. Um, I don't know if it's any consolation. In the U.S., we had our own report like this. It was about 4 decades ago now, and we made some pretty systemic changes in our response to that. And it's I can't say it's changed the industry, but it certainly gives us a better window into what's going on in these care homes. Also, I don't know what your COVID pandemic experience was like, but there was a huge spotlight on nursing homes in the United States, largely because nursing home patients were about 30% of the overall fatalities from COVID-19, at least in the first 3 waves. And we envision that as we move into new variants, nursing home patients are probably the most vulnerable, the least likely to respond to vaccines, and are going to become susceptible to the new variants as well. So in thinking about how to leave you with something from this talk, I thought I'd start with some really bad strategies for that. And some bad strategies for implementing change in care homes would be to give a lecture and think that was it, to order, as doctors and providers, order nursing delirium assessments, try and go and report the delirium problem that you have in your care home to the administration, and you can always hope for change. So all of those are, please trust me when I say they're pass-failed strategies. I'll give you an example. Many of you don't know that I'm the world record holder, and I hold the world record for the most delirium lectures without clinical impact. I'm really proud of this award. I've spoken all over the world on delirium, and I think that my lectures have had pretty close to 0 clinical impact. So hopefully I do better than that today. I keep trying. Hoping for a different outcome, though, is not it's some people's definition of insanity. There are some strategies that have proven winners in any healthcare setting, including care homes. So the first thing I would say is broaden your focus. If you go to a nursing home administrator and say, we have a delirium problem, they're going to look at you like you have a delirium problem. So the idea is that delirium is very poorly coded across the world, and so often to gain foothold for delirium, we have to associate it with other problems. The great part is pick your nursing home or pick your care home challenge, and largely delirium is associated with that. So if your care home has an issue with falls, with hospitalizations, with functional decline, with antipsychotics, all of those are interrelated with delirium. And so combining forces to fix one problem can often have impacts in other areas. The second part is building a team. In the US, they're called nursing homes, and that's because they're not run by physicians. They're run by nurses. And so to think that me as a physician can have significant impact on the way the care is delivered in a nursing home, it's a little naive. So you have to build a team. You can't go in there in the hierarchical structure that is medicine, at least in the U.S., and expect to invoke change. You have to go in, build a team, and that includes those frontline nursing care assistants who are delivering that care that's really hard to do, and they're overworked and underpaid, and it's not a great job to do. You need to enlist their support and engagement in this process. The other thing I'm going to say is that we have to think about streamlining our work. If you go in and say, we're going to do delirium assessments, I think you're starting on a losing strategy, just because just assessment alone isn't going to make anyone's life easier. It really starts beginning with communication and then working potentially towards interventions. if you're going to think about implementing Delirium, I would focus on a very, very brief assessment. And my example is the MRAS. I know that the squid is also has some popularity in Australia. And so, I would stick with one of these. The RAS is simply asking an open-ended question to a patient and seeing if they can stay on track for 10 seconds. Describe how you're feeling today. That can be incorporated into routine care. And then the RAS is scored by the admitting provider, or not by the admitting provider, but by the professional team member there. Nurses can do it, nursing assistants can do it. It's not very hard. The MRAS has been validated in a number of studies now, and people with a positive MRAS or a negative MRAS are more likely to have delirium. I would roll that into a structured communication tool. And these are catching on because nurses find them a very effective way to communicate with physicians. And physicians like them because it gives them much more objective data. If a nurse calls you and says, my patient's off the wall, or my patient's bonkers, you don't know how to process that as a clinician. However, if you use a numeric scale or give an objective measure, the squid was positive, the patient's MRAS is +2, and this is a change from baseline, that really gives a clinician an understanding of what's going on in the situation and can make a much better decision, as well as it fosters that gap between the way nurses communicate and the way physicians communicate. So these are some simple strategies. Hopefully you'll be able to think about using one or two. And some final thoughts. Care homes are really important places, right? We value life in our societies, and even as functional capacity wanes, the care home provides necessary services that we just can't give in other locations. And the other part is so much of the care that happens in these care homes intersects with delirium. And so there's a real opportunity to build coalitions and improve care, not just in delirium, but overall in the care facility. Thank you. I look forward to joining you at the next Australasian Delirium Association meeting in Australia. And thanks, and we appreciate any questions. Talk soon.